Today we are going to discuss the case presentation of tubercular meningitis in children. Before starting it, you should know a brief background about tubercular meningitis. Tubercular meningitis is most common chronic meningitis in Indian children. Also, you should know what do we mean by the word chronic. The word chronic here means any leptomeningite disease with clinical and CSF inflammatory changes that persist for more than or equal to 4 weeks. Okay, so whenever a picture of chronic meningitis comes to us, TB is one of the most common causes in Indian children. Also, you will find such cases frequently in your pediatric wards. Now, coming on to what can be the other causes of chronic meningitis, we should know about the other causes as well, so as to rule out any other pathology other than tuberculosis. The causes of chronic meningitis can be broadly divided into infectious causes and non-infectious causes. Amongst the infectious causes, in the bacteria, most common tuberculosis, brucellosis, borreliosis, listeriosis, leptospirosis, and syphilis. Among the viral causes, HIV is most common, followed by cytomegalovirus and mumps. In case of fungal CNS infections, mostly seen in immunocompromised states, it could be cryptococcal infection, histoplasmosis, blastomycosis, or it can be nocardiosis. And finally, on the parasitic category, cysticercosis and toxoplasmosis should be taken into account. In non-neoplastic causes, non-infectious causes, there will be neoplastic and vasculitis. Neoplastic leukemia, NHL, and primary plain malignancy would also present as chronic meningitis, and autoimmune vasculitis causes SLE, Sjogren-Bechet syndrome, sarcoidosis. They all can present with chronic meningitis. Now, coming to the history presentation. First of all, whenever you present a history, it should begin with the presenting complaints, the chief complaints. They should be not be more than 3, can be 4, 3 to 4. You should limit yourself. Okay, so and these have to be listed down in the chronological order. Okay, you have to in the chronological order. First of all, the weight of the child. Right, weight is a really important factor when it comes to describing tuberculosis. So the first chief complaint could be the loss of weight and loss of appetite, right, for the last 1 month. This 1 month duration is really important because 1 month duration is really important because whenever we are saying that the child has this pathology for more than 4 weeks, that is around 4 weeks, 1 month, then it indicates towards any chronic pathology rather than an acute one. Okay, so the second chief complaint could be fever that is on and off, and that lasts for 15 days, for the last 15 days, followed by multiple episodes of convulsions 4 days back, followed by altered consciousness or sensorium since that convulsive episodes. Okay, you can also add any focal neurological deficit if there is present, like hemiparesis, lateral squint, or headache. These are the signs of raised ICP, and this is a sign of a cortical involvement. Okay, now coming to history of presenting illness, these are the chief complaints. Now, in the history of presenting illness, you have to describe all these in a chronological order as if you're narrating a story of what exactly happened, how and when. And details are really important. So you have to describe everything as if a suspense story is going on. right? You have to focus on the details. I've put this figure here. If you have seen The Good Place on Netflix, then you would know that details are really important. Tiny details help you to figure out what is exactly happening. The suspense of the story lies in the details. Okay, so in the history of presenting illness, present your history in such a way that every little detail is covered, everything in chronological order, so that we can know what exactly happened with the child. Okay, for example, here I've presented a history. So this child, he was apparently well a month back when he developed fever. The fever was high grade, documented to be 104, not Fahrenheit. Also, it was not associated with rigors. It was relieved by antipyretic medications for only few hours, only to reappear again. And then this fever persisted for 18 days despite the medications. By the 11th day of illness, he developed a flurry of multiple episodes of convulsions that consisted of jerking movement of all the four limbs with uprolling of eyeballs, frothing from mouth, clenching of teeth, but there were no bladder bowel incontinence. So here I am describing a generalized tonic-clonic seizure activity, and each of these episodes lasted for 20 to 30 minutes, followed by a brief recovery period, followed by next similar episode of convulsions. And when the child is presented to us, the child is in altered sensorium. And how he is in altered sensorium? He's altered sensorium in the form of no eye opening, he's not responding to the verbal commands and not recognizing the parents and not indicating for blood bowel needs. A very important concept comes in your history of presenting illness, that is the concept of a negative history. You have to understand this, that the negative history doesn't mean that all the complaints in the body that are not present in the child have to be explained. You have to explain those negative history points only that you are able to defend the rationale behind, right? You have to rule out other possibilities. That's why you're taking the negative history. Okay, for example, if there is, you're asking for a history of ear discharge, that means you have to rule out any brain abscess or any chronic suppurative otitis media picture that could have been a cause of the meningitis. If you're asking for rash, that could indicate any meningococcal or measles infection that could have triggered the tuberculosis infection. Also asking for diarrhea, because it could be enteroviral encephalitis or Shigella enteropathy, right? So when it comes to negative history, make sure that whatever no history of you are asking has a rationale behind it, and you're trying to rule out any possibility of other infections or other causes of the condition of the child, right? And last but not the least, you have to determine the extent of the involvement. First of all, describe the sensorium of the child, any focal neurological deficit in form of the cranial nerve involvement. Also, then individually, history of motor system involvement, in which the important thing is the posturing of the child. If there is peculiar posturing like decerebrate posturing, decorticate posturing, or hemiplegic posturing, we all know what all these are. In decerebrate posturing, there would be extension of both upper limb and lower limb, and the back of the child would be arched. The child will be lifted up above from the bed. In case of decorticate posturing, the upper limb would be flexed and the lower limb would be extended, and occasionally the child would show arching. Both of these posturing are an indicator of raised ICD or impending herniation in a child with TBM. Okay, and if the child is present in a hemiplegic posture means one side of the body, right upper limb, lower limb, these would be very flaccid. The child would be unable to move one side of the body, and if you're trying to lift the child off the bed, he will not be able to do so. Okay, so all this indicates the cortical involvement on the contralateral side of the body. After the motor system also includes the tone assessment. You have to ask about the tone of the child in general. The best person to ask this is mother, because mostly mothers are the primary caregiver. Whenever they are changing the clothes of the child, they notice that the muscles are either tight or flabby, right? So you have to ask if there is any tightness or flabbiness of the muscles of limb. Usually in tubercular meningitis, they notice tightness of the limbs. This tightness of the limbs indicates pyramidal and extrapyramidal tract involvement. Now coming to history of muscle power, if there is hemiparesis, then obviously there will be paucity of movements of one side of the body. So the power on one side of the body would be 3 by 5 or less than 3 by 5. That would indicate hemiparesis, and that would again point to the cortical involvement. Also, any abnormal movements like ethetosis, chorea, dystonia, myoclonus, or balismus, that would suggest basal ganglia involvement. Also, any sensory system involvement. This sensory system assessment would only be possible if the child has a fair sensorium. In cases of child with altered sensorium, we cannot assess the sensory system. Also, cerebellar involvement. We can check by the cerebral involvement by eliciting the various cerebellar signs. Or in general, if the mother says the child is very clumsy while moving, throws the objects, is unable to perform tasks fluently, then all of this could point towards cerebellar involvement. Then coming on to history of any autonomic system involvement. You can ask whether the child has history of excessive sweating, dizziness with the change in posture. This autonomic system involvement history is very important, because this autonomic symptoms, they predominate when the child have autoimmune encephalitis, right? Autoimmune encephalitis also presents with subacute encephalopathy and can be confused with TBM. So, if the autonomic symptoms predominate, you would think more in the favor of autoimmune encephalitis. Now, coming on to the bladder involvement. When bladder assessment is there, you have to first of all be able to differentiate between upper motor neuron bladder and lower motor neuron bladder. In case of upper motor neuron involvement, the bladder would be uninhibited and there would be urge incontinence, right? And in case of lower motor neuron involvement, there would be urinary retention. In TB meningitis, this lower motor neuron bladder is relatively uncommon, and whenever it is present, then it suggests that there could be any possible spinal cord pathology, like extension of the inflammation towards the arachnoid space, right? It could be arachnoiditis. Then comes history of raised ICP features, repeated vomiting, head banging, irritability, headache. Also, any meningeal signs if noted by the parents, like sometimes mother might notice neck stiffness in the child, right? Now, after the history of presenting illness, explaining the presenting complaints, followed by your negative history, followed by your particular history to pinpoint the extent of involvement, and lastly you have to somehow elicit or turn out the etiology through the history. So finally we have to take the etiological history. In this you have to understand that a basic picture that we are dealing here is a child with subacute or chronic onset febrile encephalopathy, right? And there could be or could not be focal neurological deficit. So whenever there is such a child, there can be multiple etiologies and you have to rule out each one of them to come to a particular diagnosis or differentials. Okay, so to know the etiological history in a child with subacute or chronic onset febrile encephalopathy with or without focal neurological deficit, what all history you have to ask is, first is history of rash. In this comes measles and meningococcus. Measles creates a immunocompromised state, and that can trigger latent TB infection. So history of rash is really important. Also, history of any associated or preceding diarrhea. They point towards enteroviral encephalopathy and enteric fever. Any untreated or partially treated enteroviral or enteric diarrhea may result to subacute febrile encephalopathy like picture. Any history of bleed, that could indicate IC bleed and would also present in a similar way. Any history of ear discharge indicating of CSOM, any history of sinusitis, a risk factor for brain abscess, any history of head trauma, chronic subdural hematoma or hemorrhage mimics TB like picture, TBM like picture. Also, any history of upper respiratory tract infection, diarrhea, few weeks prior, or any vaccination history. That also point towards any autoimmune demyelinating pathology, right? Also, history of any yellowish discoloration of eyes, that would involve that would all point towards hepatic encephalopathy. And history of blood transfusion or multi-site infection indicated of immunocompromised state like HIV infectious associated encephalopathy. Any history of joint pain, swelling, rash, that will tell us underlying cause could be vasculitis. Any bony pains, abdominal mass, intermittent fever, neck swelling, that would indicate cervical lymphadenopathy, would point towards any underlying malignancy. Also, history of any abnormal urinary order, unexplained lethargy, profuse vomiting, fluctuating illness. What do you mean by fluctuating illness? The illness that worsen with any febrile episode. Okay, all these points towards inborn error of metabolism, including the mitochondrial disorders. Also, history of travel. History of travel to any hilly area or any possible tick bite, all these could suggest any rickettsial infection. Also, if there is any history of prolonged drug intake or toxin exposure, can also lead to toxic encephalopathy. It is important to ask the profession of the parents if and all they work in lead factories that involve constant exposure. This can lead to lead encephalopathy. This is all about the history. Then coming on to examination, neurological examination needs a separate discussion. Here I am listing just two important points that you should take into mind while presenting the history and examination part. This is really important state of consciousness. People usually confuse how to present or tell whether the child is conscious, minimally conscious, he is in vegetative state, coma, or brain dead. For this, you have to assess three parts. First of all, consciousness, it includes two most important elements. One is wakefulness, that is regulated by reticular activating system. Wakefulness indicates that the sleep wake cycle of the child is preserved or not. Then comes awareness to self, surroundings, and the self, surrounding people, and the environment, right? It is controlled by frontal cortex. And finally, brainstem reflexes. When the child is conscious, obviously the sleep wake cycle would be preserved, awareness would be preserved, and the brainstem reflexes would be present. In case of minimally conscious state, wakefulness would be there, brainstem reflexes would be there, but the awareness, that would be partial, right? The child would be confused. It comes to vegetative state, wakefulness would be preserved, brainstem reflexes would be preserved, but he won't be aware. In coma-like state, wakefulness is also gone, awareness is also gone, plus but brainstem reflexes are present, and we label brain death when there is no wakefulness, sleep-wake cycle is not preserved, awareness is gone, and brainstem reflexes are also gone. Also, there are certain signs in the general physical examination that could point towards that neurological illness. For example, pallor, that could indicate any icy bleed or cerebral malaria. Icterus would point to hepatic encaph, leptospirosis, or complicated malaria. Rash, again, meningococcal infection, measles, or any rickettsial infection. Petechiae could indicate dengue, any viral hemorrhagic fever, or meningococcemia. Any head or scalp hematoma would suggest some head trauma. Okay, finally, just a small mind map discussing the management strategy of a child with tubercular meningitis. It includes immediate management and urgent investigations. Finally, workup, followed by management, supportive care, discharge, and follow up. When it comes to immediate management, the vital steps in a child with altered sensorium is you have to ensure ABC, that is the airway, breathing, and circulation. Then secure IV cannula, and the as soon as you secure the cannula, withdraw the samples at the same time also, right? Procure the urgent samples also. The urgent samples are blood sugar. You have to look at the blood sugar to rule out any hypoglycemia. Electrolytes, sodium and potassium, to rule out dyselectronemia. Urea creat to look at the renal functions. Hemoglobin to look at any degree of anemia. TLC to look at the leukocytosis if the picture is there, and platelet rule out thrombocytopenia. Thrombocytopenia can also cause bleed, right? Also, sometimes the child may present to you while seizing. If the child is present, is here in front of you in the emergency seizing, then load with phenytoin at 20 mg per kg, followed by maintenance dose at 5 mg per kg. Also, if there are any signs of raised ICP, give a stat mannitol dose at 5 ml per kg, followed by 2 ml per kg 6 hourly. This is the immediate management and urgent investigations that have to be sent. Now, coming on to the workup, it includes imaging and certain investigations. The readily available one and quicker is CECT brain. It is preferred in cases when the child is sick and intubated, and you cannot waste your time in doing MRI, right? So CCT brain can easily show us or help us to look at the certain markers or pointers towards the TB pathology, like basal exudate, tuberculoma, any hydrocephalus, and also you can rule out brain abscess easily via CECT brain. Fundus examination to rule out any changes related to raised ICP. We are looking for papilledema. Lumbar puncture, once the raised ICP is settled, you do lumbar puncture and send the CSF sample for cytology, protein, sugars, culture, TB PCR. Also in immunocompromised stage, cryptococcal antigen, parasitic infection, acanthamoeba, wet mouth, you can send, right? Also, if viral encephalopathy is in suspicion, then viral panel can also be sent. MRI brain is preferred when there is no emergency like situation, the child is relatively stable. Then MRI brain with contrast is preferred because it will give the details of the structures better, and the pathology could be delineated better. And finally, TB workup, which includes Montu test, chest X-ray, GA for AFP. Also, you can also do a parental screen for TB. That would also point towards the contact, and we can give or start ATT on the basis of clinical suspicion. The core management includes starting ATT along with IV dexamethasone if the chest imaging, if the brain imaging, and CSF clearly suggestive of TBM, then we have to start ATT along with IV dexamethasone. Also, take a neurosurgery consult. Uh, Let them comment if all the child requires shunt surgery. If the imaging and CSF is not suggestive of TB, then start the child on broad spectrum antibiotics and acyclovir. Comes supportive care. These child in altered sensorium, right, not able to tell their bladder bowel needs, they need special care. First of all, you have to take care of the nutrition. If they're not able to take feeds well, NG feeding could be demonstrated, and the nutrition and calorie intake of the child should be monitored. Care of the bladder is important to prevent UTI. Care of bowel, prevent the constipation in child. Care of eyes, instill methylcellulose drops to prevent corneal scarring. Because these child are sick and bedridden, care of the back is really important to prevent any bed sores. Now coming on to discharge and follow-up. You discharge the child when the child is tolerating feeds, the fever is settled, the sensorium is improving, and mother is well trained now for giving supportive care. Then you can discharge the child on ATT, steroids, and acetozolamide if shunt surgery is not done, and ask them to come for follow-up after 2 weeks. After 2 weeks in the OPD, you will reassess the sensorium of the child, look if there is any residual neurological deficit, start occupational therapy, physiotherapy, and address any of the feeding issues that the mother is having. And that's all about TBM. Hope you find the session helpful. Happy learning. Bye bye.